I am pleased to introduce Dr. Gagan Singh, who is the Chief Medical Officer at Mercy Care, to introduce the first session of the day.
Good morning, everyone. I'm Gagan Singh. I'm a psychiatrist who's had a chance to have many end-of-life decisions with my patients on the consult service. Also somebody who created my advanced directives pretty early, in part because of that, and I've often wondered, will my care providers know what those are? I also am the Chief Medical Officer for Mercy Care. As Melissa mentioned, Mercy Care is a proud gold sponsor for this year's Contextia Summit and Trade Show. Mercy Care is one of the largest access plans in Arizona, providing access to integrated physical and behavioral whole person care to more than 500,000 Arizona natives across the state. We serve people in need, families, children, seniors, and special populations, including foster care kids, people with intellectual and developmental disabilities, and people with serious mental illness designations. Starting on October 1st, we're expanding our SMI healthcare services to Gila and Pinal counties beyond what we provide in Maricopa County. Our continued support for Contextia and this annual summit and trade show underscores our commitment to enhancing care, improving quality, and lowering costs through the statewide health information exchange. Now, most importantly, I'd like to introduce Carla Sutter, who will moderate today's panel session, Let's Be Direct, the Arizona Healthcare Directive Registry's impact around the state. She's the director of the Arizona Healthcare Directives Registry for Contextia, Arizona's HIE. She also holds a master's in social work and has spent 30 years working with organizations that are dedicated to helping clients and families care for themselves and others whose needs are changing due to age or illness. She served as a volunteer in helping develop the end-of-life decision-making tool for healthcare settings across Arizona. She's also the author of Where Do We Begin? A Guide of Elder Caregiving. This panel session will provide insight on the steps that organizations can take to participate in AzHDR and how they can work through it to enhance patient-centered care and provide clinicians the information they need to guide treatments and interventions on behalf of their clients' wishes. So let's welcome Carla and her amazing panel. Thank you.
All right, thank you so much. I look forward to this time and sharing what our panelists have to say in regards to both advanced care planning along this continuum and with the Arizona Healthcare Directives Registry. And you can see that I'm not very good with technology, so to get to the next slide. There we go. Promise this is not going to be with each slide. We're not going to do this. There we go. Imagine that your mother, your father, your spouse, your adult child has had a medical crisis. They are not expected to recover. Who will speak to the healthcare team for them? Who will make these decisions? And do you know what decisions they would want? And if these documents were completed, are they accessible when and where they are needed? My family faced these very issues in December 2015. My dad was in the ICU with an unknown infection that ended his life 8 days later. The decisions that we had to make during those 8 days were not easy, but we will always be grateful that as a family, we had completed our healthcare directives in advance and were able to use these directives to guide decisions during the end of his life. While one may know or believe they know what someone wants, having their wishes documented and being able to see them in black and white eliminates any questions, allows individuals to trust their decisions, and inform those who are providing care. My dad was a teacher for 40 years, and as he shared in his application for his body donation to the U of A, he was a teacher his whole life, and in his death, he wanted to teach others. His favorite saying was one that was carved into a university building where he did research. Wisdom is the principal thing. Therefore, get wisdom, and with all thy getting, get understanding. It is stories like ours that I hope will make a difference and help ensure that others will communicate, document, and finally register the advance directives for themselves or their patients. There is almost universal agreement that knowing a patient's medical preferences and being able to easily identify their designated healthcare agent enhances patient-centered care. In fact, a study of the electronic records of over 1,100 cancer patients over a 2-year period found that those who had advanced care planning were less likely to be admitted to a hospital in the last 30 days of their life. Those who had made plans at least 6 months prior to their death were even less likely to be hospitalized. Another study of over 1,500 bereaved family members reported that the completion of an advance directive was associated with greater use of hospice and fewer reported concerns with communication. But despite statistics such as these, opportunities remain to improve the quality of end-of-life care. And with all our knowing, only 30% of the nation over the age of 18 have documented their medical preferences. We all hope to be able to communicate to the end of our lives, but too often it doesn't happen that way, and too often the situation changes too quickly to be able to make decisions at the time when they are needed. Without a plan, without it being documented, our healthcare teams, our family, our loved ones won't know our wishes and healthcare preferences. But if conversations have occurred, but they were not documented, our family will forever question if they were remembering correctly and whether they are making the right decisions. And if those conversations were had and they were documented, are they available to those who need them at the time they are needed? As I shared a few minutes ago, my family and I have done the work and completed our directives. But a situation occurred that schooled even me on a few things. First, being the subject matter expert on the advance directive registry in real life doesn't make your advance directives any more viewable than the average Arizonan. And that the AzHDR is key to ensure that the hard work that went into completing advance directives matters in the end. In November 2021, while the AzHDR was going live, I was confident I knew exactly where in my house my directives were stored. Unfortunately, at the same time, we had a plumbing catastrophe and the house was in disarray, to put it lightly. I could not find the directives anywhere. I realized that if I couldn't find them in a medical crisis, my healthcare POA would certainly not be able to find them either. So I rewrote them, had them witnessed, and registered them. Knowing that they are now registered with the AzHDR has given me reassurance, along with the ability to authentically and with no sense of hypocrisy talk about the importance of the AzHDR. And as you will see later, features included in the AzHDR, such as the wallet card, can safeguard these documents and make them accessible to all healthcare providers or healthcare surrogates, so that even if there is another flood in my house, access to these documents is certain. It is now my honor to introduce our panelists who are joining me today. It is our hope that you will walk away from today's session with a few important takeaways. One, a better understanding of the Arizona Healthcare Directives Registry and how your organization can and should be participating. Two, the interplay of community organizations and healthcare providers throughout Arizona. And three, the diverse way of looking at advanced care planning and registration, moving away from the idea that you must be of a certain age or living with certain medical conditions to complete and register advanced directives in Arizona. So I'd like to introduce our panelists. Either that or am I doing something wrong? All right. Cindy Leach is the Vice President of Long-Term Care at Mercy Care since December 2020. She brings over 35 years' experience in healthcare administration, financial management, executive leadership, and program development to this role. Her responsibilities are to develop, implement, oversee, and evaluate the Mercy Care All-Tex program while leading a large case management department. She ensures that appropriate and cost-effective medical and medically related social and behavioral health services and supports are identified, planned, obtained, and monitored for individuals eligible for All-Tex services. In addition, she develops connections and partnerships within workforce development, home and community-based services, and institutional programs. She holds a BS in Health Administration, an Associate's degree in Nursing, several licenses with the state of Arizona, including licensed nursing home administrator, assisted living manager, and registered nurse. Jennifer Martinez is the Vice President of Administration at Spectrum Healthcare Group. Through statewide community solutions and focused care, Jennifer and the executive team are meeting the whole health needs of Arizona populations. She draws on 18 years of experience to further Spectrum's mission of bringing whole health to the communities they serve. She is passionate about being an agent for change in our healthcare system, and she holds her Master's of Business Administration. Matt Osborn is a sales manager with Desert Financial Credit Union. He's been a Valley resident for over 36 years and has spent 20 of them at Desert Financial Credit Union. Most of his financial services career has been devoted to their wills and trust division. He's personally helped thousands of families prepare legal documents and gain peace of mind by having an estate plan in place. He takes pride in training, coaching, and managing his team of 13 estate planning specialists. He believes in the power of educating people about their planning options. Amy Schwabenlender is the Executive Director of the Human Services Campus, HSC, in downtown Phoenix. The HSC is a collaborative force of partner organizations united on one campus to end homelessness. Located just west of downtown Phoenix, 16 independent agencies on the campus serve nearly 1,000 individuals every day with a holistic range of client services, including reunification, mental, physical, and dental health, temporary shelter, employment, meals, legal services, and housing. Having all these resources in one location with intra-agency communications makes it more feasible to provide a customized engagement for each client. She is a 2016 Piper Fellow and a graduate of Valley Leadership, and she holds a BS in Business Administration and Communications and an MBA. All right. This is going to be my legacy with this one. After hearing the bios of our panelists, you can imagine that we are going to have a full agenda, and I look forward to talking with each of the panelists as they share how they are interacting with the AzHDR and the types of organizational work they are doing to incorporate the registry into their workplace. It is our hope that hearing from these diverse organizations will allow all of you to be thinking about how the AzHDR can be developed into your own workforces. So I want to share a little bit about where we are with the registry. So the Arizona Advanced Directives Registry was actually created in May of 2004, making it one of the first states to recognize the value of an online registry for advanced directive documents. And until November of 2021, the Arizona Secretary of State was the home for the Advanced Directive Registry. Thanks to a 2019 legislative change, Contexture became the new home for the registry. And as of November 2021, we transitioned over 73,000 accounts on that day. As of today, over 85,000 accounts are live in the AzHDR and accessible to participating providers across the state. So that we're all on the same page with what advanced directives are in Arizona, I just want to provide a very brief overview. The most important piece, though, that I can share is that advanced directives should be viewed as documents of choice and not documents of limitation. Identifying them as such opens the landscape to a wider population while enhancing health equity for all. So the AzHDR accepts healthcare directives submitted in compliance with the healthcare directives law, a living will, healthcare power of attorney, mental health care power of attorney, and pre-hospital medical care directives, or the out-of-hospital DNR, in whatever form they come in on and whatever template they come in on, can be housed with the registry. There's an additional focus on incorporating other documents into the registry as well that are part of the advanced care planning continuum. And these are included, but not limited to POLST documents, organ donation, and HIPAA documents. The greatest value of advanced directive documents is certainly the content that they contain, but that value only pays off when they're accessible, when and where they are needed. The work that we have been doing since before 2019 could not happen without the support of many sponsors, donors, and community champions. Well, research shows that advanced care planning models improve multiple outcomes for seriously ill patients. Many programs can be too narrow in their focus. And to avoid the pitfalls of most advanced care planning programs, an integrated approach is required. And as we move through the presentation and you get to meet our panelists and hear more about the AzHDR, you'll see how the multi-pronged manner that we have laid out to reach our goal is working. This addresses the four primary stakeholders that a successful and sustained program needs to: patients, providers, healthcare systems, and communities. La Crosse, Wisconsin, which is often referred to as the town that knows how to die, instituted a system-wide project called Respecting Choices at Gunderson Lutheran going back to 1999. And since then, they've worked with health systems across the world to train and design and implement programs focused on advanced care planning and person-centered end-of-life care. As you can see with some of these statistics, for instance, in 2008, 90% of the people in La Crosse who died in a hospital had an advanced directive, and those who died received the care that they wanted and was explained in those directives. People who die in La Crosse spend about 32% less in the last 6 months of their lives compared to the average Medicare patient. One of the key components to the La Crosse program is a sustained and consistent approach which begins with the staff themselves and is woven into all healthcare organizations in La Crosse. And while these statistics may be unique, they are not aberrations, because they face the same operational and organizational issues that all healthcare organizations face today. While issues exist across patient groups in regard to having advanced care planning conversations with their providers and completing advanced directives, vulnerable populations experience disparities in access to advanced care planning and often have unmet healthcare needs at the end of their life. One group that is often not included in advanced care planning for a variety of reasons are patients who are experiencing homelessness. This population has increased morbidity and mortality risks and lacks opportunity to discuss end-of-life preferences. Advanced care planning is crucial antecedent to receiving patient-centered care, particularly for vulnerable populations. And I've had the opportunity to begin working with Amy from the Human Services Campus, and she's going to share some information about those individuals that they serve. As you'll see, this program is based on the recognition of the power of a 360-degree, no wrong door approach. Amy.
Thank you, Carla. Thanks for including us and this population of people experiencing homelessness in the conversation. Thanks for thinking outside of the box and approaching me to start this conversation many months ago. To set the landscape of when we talk about homelessness in Maricopa County, this is the data for the entire region. And people continue to ask, did COVID cause an increase in homelessness? A 2-year global pandemic certainly contributed and continues to contribute to an increase in homelessness, particularly unsheltered homelessness. What we also know leading up to 2020 is that Maricopa County, Phoenix in particular, has had rapid population growth for decades. We have an underproduction of housing at all affordability levels, and we don't have income that keeps up with the increase in the cost of living and the cost of housing. And so today we face an affordable housing gap in Maricopa County of over 270,000 units of housing. And that bar graph then demonstrates when we count as a region through the Maricopa Association of Governments, the Regional Continuum of Care, there wasn't a formal count in 2021 due to the pandemic. The jump from 2020 to 2022 was over 30%, particularly in the unsheltered number. We don't have enough shelter beds for every single person that falls into homelessness in our region, and so that unsheltered count continues to increase dramatically. Around the Human Services Campus in downtown Phoenix, we shelter over 900 people every night in a variety of spaces, and we have an unsheltered population in our neighborhood of over 800 people. Our outreach team counts the folks once a week. They do engagement every day. This morning they counted 805 people between, if you're familiar with downtown Phoenix, I think everyone, this is statewide, right? Maybe not everyone understands the geography from 7th Avenue to 15th Avenue, the railroad tracks to Jefferson, a rather small area, 805 unsheltered people last night into this morning. Next slide. And we also know homelessness is a regional issue, so it's not just a downtown Phoenix issue. We work collectively with dozens of partners across the valley. This is the unsheltered map from this year's point in time count, which shows you that people are experiencing homelessness, they are in unsheltered spaces across our entire region. So any solution that we can find that connects people to resources and helps them move out of homelessness into housing really affects our entire community when we think of Maricopa County. Next slide. As Carla mentioned, the Human Services Campus is a collective of about 16 partner organizations. We all work together to serve individuals and move them into permanent housing. We do see families, we do have youth on their own that show up, and we quickly refer them out to other partner organizations like UMOM New Day Centers, Homeless Youth Connection. Our focus in this data is really about the people who come through the front door of our Human Services Campus to paint the picture of when Carla starts to ask me questions about what we're working on together, who we're serving at this place in downtown Phoenix. And this is our fiscal year 2021 data. We're continuing to finalize our analysis of fiscal year 2022. So these numbers tend to be the same when we look year over year. The population that comes to us tends to be more male than female. And while a lot of conversation, what hits the news tends to be about the aging of the homeless population, which is real and it's a thing. And we have lots of empathy for youth, which is real and is a thing. It's still that the majority of people that we're serving are in that age bracket of 35 to 61 years old. And those tend to be the people that haven't done this type of planning, and it's probably not even on their radar to start thinking about it. And then when we look at the population of 62 and over, we do find a lot of people who are first-time homeless, and planning for what happens next is really not something that's top of mind for them and hasn't been something they've been thinking about, and suddenly they're faced with all these decisions in a very stressful and potentially further physically harming environment. Next slide. Also want to talk about race and ethnicity. Definitely we have a health equity lens in our work. We also have a race equity lens because the chart on the left shows you that people who identify as Black and African American, which is that, I can't read my own numbers from here, it's the gray, it's an overrepresentation of people of color in our homeless population compared to the population of Maricopa County. The population of Black people in Maricopa County is somewhere around 8 or 10%, depending on what study you look at or what set of demographics. It's 30% in our single adult homeless population. So everything that we do, we are including the conversation about how do we make our processes more equitable, how do we remove bias, and how do we really get to the core of why people of color fall into homelessness more often than their white counterparts. Next slide.
That is the slides.
Oh, is that it? Okay, perfect. Your slide, Carla.
All right. So, Amy, thank you for, that is the last one for you.
Oh, thank
so
you.
I'm going to go right,
Okay.
and I'm going to leave this up because it is powerful, and I want to have that number up for everybody.
Thank you.
But thank you for sharing these slides and allowing all of us to see the reality of these numbers. And so I want to talk a little bit more about the ways you and I have talked about looking at advanced care planning. And what was interesting is after my visit to the HSC, I also began to see some research that's been done around homeless adults and advanced care planning, and that they had a lower percentage of completed healthcare directives and medical records than the national average, which, as I shared, is 30% and already low. But similar to national statistics, these individuals have thought about the type of care that they would want and who they would want to make decisions based on their behalf. Research participants in some of these projects were receptive to private meetings about advanced care planning and more likely to complete an advanced directive if it was done during these meetings versus being provided materials to complete on their own. And this fits directly into what you and I have been looking to develop. So we've talked about working to begin to offer monthly office hours at the Human Service Campus, where the AzHDR team and those who have been trained can assist clients with completing their advanced directive documents from beginning to registration so that they leave with the registered and have a printed wallet card to keep with them. So can you talk a little bit about how the HSC team sees this approach working with your clients and the impact that you think this could have?
Yes, thank you. And the campus, if you haven't been there, we have 8 buildings, 13 acres, and people have lots of ideas at times of what programs and services to bring to our population, assuming that others know what people need. Carla invested the time to really tour the campus, to attend one of our campus council meetings where all partners meet monthly to talk about how we can improve and continue our collaboration, coordination, and move more people into housing. And so she was really able to observe and hear from partners themselves about how we can start something new. Our population tends to lack a lot of trust in systems, lacks trust in government. So if we said this had been the Secretary of State, a lot of people would probably tune out and not want to engage. But working towards a space where Carla and her team can rotate through, we find that that's a way that clients like to start their first conversation. It gives them a way to learn something new. Even if our clients know how to use technology, even if they have a mobile phone, they're not, their day is so stressful thinking about when am I gonna miss the meal if I don't get in line? Do I have a shelter bed tonight? If we were to give them a task when they walk through the gate and say, here's information on the Advanced Healthcare Directive and here's the website, they probably wouldn't do anything about it. So really creating this in-reach type of opportunity to meet people where they're at and to do that in a friendly, hospitable way, we're looking forward to getting that started.
That's great. Thank you. We're also working, though, on introducing an advanced care planning ambassador training for HSC and other collaborating campus organization staff as really a pilot for across the state. And this would be a training that gives your team tools and knowledge to confidently and routinely start a planning conversation to help clients make and execute a healthcare directive. So talk about how you see the impact of leveraging trusted relationships that you already have built with your clients and how that can aid in increasing these conversations and documents especially with customized training for the staff?
About 20% of the people that we serve are considered chronically homeless, so they're long-term homeless or have multiple episodes of homelessness, and they have a disability, whether that's physical health, mental health, or 2 or more things at one time. And our staff, a lot of the outreach staff, a lot of organizations have case managers or housing navigators, and they're building that rapport and relationship with clients to guide them through this, what can be a 2-year journey to housing because of all those other factors I mentioned. So when we can also teach our staff how to do this registry process and put the tool in their hands, they can have the conversation when it's more natural for them as they work with their client. So I think both ways, the office roadshow will engage a segment of our population, and then another segment of our population that does tend to find the staff person that they really trust and will engage with. Once they have this in their toolbox, they can also offer it at the right time.
And if you can share, this is, again, kind of thinking outside the box, although from what I have seen on the campus, that happens a lot. So again, you've kind of talked about it, but if you can share maybe a short success story your teams have had when bundling in additional services that may have been kind of outside of the box of what was typically thought of that would happen in a conversation.
One thing that we recently brought back, it existed and kind of went away, are what we call source specialists, individuals who really advocate and help people with their SSI and SSDI application. Again, the demographics of who we're serving, there are a lot of people that fall into that category of being eligible, and they're not necessarily successful on their own, submitting, completing, and getting approval of their application. And again, having staff that just work with a small caseload of maybe 15, 20 people at a time, they're taking them through that process, and there's a much higher success rate of an application being approved the first time because there's a trained professional individual documenting their medical history. And so I think that's also one area to tie in the Advanced Healthcare Directive. Another new thing we're working on, a national organization called KEEP, K-I-I-P, is creating a data locker. That's an online place for document storage. And so that's another tool that we're working on. Again, I think connecting the registry card into this data locker. So people lose paper stuff all the time. And so the more we can connect all of these dots and teach people how to put their necessary documentation in a portal online, and maybe they give someone else the power to access those documents, then we're really setting people up for greater success.
Great, thank you so much. I really appreciate your expertise on this and sharing, again, something that is not always what we think of as a traditional population that we're going to talk with, but I hope that, again, having Amy and the rest of the panelists here kind of gets us all thinking about ways that we can integrate the registry and the work that goes into the documents leading up to registration in different ways throughout the state. So with that, I'd like to talk a little bit about that. At the beginning, I shared that diversity was going to be talked about in a variety of ways. The diversity of community champions is key to enhancing the utilization of the registry and its build-out. It may be a surprise to some to think about the impact that financial, particularly financial, but legal organizations have on building out the Healthcare Directives Registry. Desert Financial Credit Union was one of the first participating providers with the AzHDR. We reached out to them when we saw how many documents were being mailed in every day by their organization. And while we can't go back and know how many of the initial SOS documents came from Desert Financial, we do know that since we began taking in documents to Contexture and the AzHDR, that they have submitted more completed documents than any provider in Arizona. And today they have sent in 16% of the new accounts we have registered since November of 2021. So Matt is going to give a brief overview of the Desert Financial Department that he manages. There's a breakout session later today that they are also going to be hosting to share a little bit more about the programs that they have at Desert Financial.
Great. Well, thanks for having me. Most people don't really connect financial services, right, to healthcare, but, you know, and I know you're going to ask a question about that shortly. So we are certified legal document preparers. That is a Supreme Court certification. There's a program that the Supreme Court came out in 2001, and that allows non-attorneys and individuals as well as entities to prepare legal documents. And so that's what we are at Desert Financial. We're a legal entity, certified legal entity to prepare documents, as well as all of our staff are also certified to prepare documents. And over the past 15 years, we've assisted over 20,000 individuals and families prepare those documents. And we've been sending those things to the Secretary of State since we started. So hopefully that 16% transfers into the 83,000 that are out there. And so we prepare, obviously, medical directives is what we're talking about today, and those financial powers of attorney, as well as last wills and living trusts. So that's really kind of the core of what we do within our little department at Desert Financial.
Thank you. So Matt, again, as we've talked about many times, this is unique that, again, and a surprise to us when we saw how many envelopes were coming in under Desert Financial's name. But talk a little bit about how your organization approaches advanced care planning with both your clients and the staff themselves, given that you are not traditionally thought of as a sector that would focus here.
Yeah, it's really simple. The vision of the credit union is a pretty simple vision. It's to provide exceptional experiences through financial solutions that make lives better. And so providing medical directives to people definitely is impacting their lives. So this vision really of the credit union really fits in. You've cited the statistic a couple of times today about 30% of the people prepare documents, so that extends to this room. And I'll just flip that on its edge, right? 70% or 7 in 10 have not prepared any of these documents listed here. So there's a true need for that, and our executive team at Desert Financial realized that estate planning and all these documents are really part of financial solutions when we think about helping people grow their money through their investments, protecting their money through insurance, and providing a legacy. And so that estate planning really fits in with providing those financial solutions.
I had the opportunity to do some training with your team recently and was really struck by how engaged they all were on this topic and how their questions clearly showed that they understood these documents. Can you share a little bit about how you prepare your team to have these conversations and then how you overcome barriers to completing these documents with clients?
Yeah, so I've had the privilege to be with the team since its inception for 15 years, and we've grown the department from 4 to 24, as you had on the slide there. And so every time we really hire and recruit, we're really looking for people that have those personal experiences themselves with preparing documents or having their family not prepare documents, right? We all have stories and backgrounds where things went smoothly because documents were prepared correctly, and where things were a disaster, even at the hospital, when the family couldn't agree, siblings couldn't agree on the end-of-life decisions for dad, and how that can tear apart families. So the people that we hire have that compassion, they have great listening skills, and I think what differentiates us from other estate planning firms out there across the valley is that we really have an educational focus. Our focus is really to listen to people's goals, to really educate them about how these documents will satisfy their goals and wishes, and really thoroughly explain these documents. When you pull up the powers of attorney even online, right? The Attorney General has the medical directives online, and anybody can pull those off the website today. But when you print those out and your staff looks at those things, I think sometimes those are full of some legalese, and sometimes they're written in double negatives because the lawyers kind of get involved with that. And so I think that our strong suit is we provide that education to really boil down the documents in layman's terms so people can understand the choices that they're selecting.
That's great. You know, when we've talked and when you are sharing all of this, it kind of relates back to something I've always thought of as the idea of control, and that in our lives there are things we can control, things we can influence, and things we can't control. And you know, too often we put our energy, time, money into the wrong bucket. But I think the work that you're doing across and work with advanced care planning allows people to begin to influence some of those areas they can't control. As a former hospice social worker, my patients could not control the disease that they had and the end of life that was coming, but they could influence by the management of their symptoms, the way that they addressed their advanced care planning. And I see that as the work that you're doing and hopefully what we can get others here to be thinking about. So thank you. So I want to now transition to speaking with our two other panelists from what we normally would consider more traditional sides of advanced care planning, the healthcare systems. So research has shown that advanced directives provide critical information to clients, doctors, and family members about their medical preference. A survey I recently saw of ER doctors across the country found that 93% of ER doctors feel less frustrated, and 88% felt that the family members were more satisfied with the medical care when the advanced directive was available to them. CMS, as we know, has several requirements around advanced care planning for licensed organizations. And as we're going to talk about a little later in the session, there are new requirements for certain provider types under DAP 2023 milestones and the relation to AzHDR. So I want to begin with Cindy for Mercy and Mercy Care. And share a little bit about how Mercy Care has worked with your staff to ensure that they have the tools and resources to have discussions with their members about advanced care planning.
Okay, thank you, Carla, and honored to be here, and thank you for asking me to be part of this wonderful conversation that is out there. So I oversee a department of over 250 case managers in the All-Tex program, and we serve over approximately 11,000 members between Maricopa, Pima, Gila, and Pinal counties. And so we train our case managers extensively on advanced care planning and end-of-life decisions. Every new case manager that comes in through orientation receives hours upon hours of this training so that we ensure that they can educate the members and also any responsible party family members that they are working with in regards to the members. We also provide 2-hour refresher training courses throughout the year, but on our educational library, anytime a case manager feels that they need to look up and make sure that if there's any changes, well, if there are any changes, we ensure we get that education out there. But we also partner up and look for any external training that we can offer, and of course anything that is any on web related that we're able to do. All of our training is member-centered approach. So if we have a member that is hesitant in regards to talking about the ACP, we actually use talking points, and we will work and educate with our case manager talking points that they can get through some of those conversations with our members. The goal always is preserving and maintaining the dignity of our members, and that is the one main thing that we try to do with all of them.
That's great. And I know that we're working with Mercy Care to incorporate the training around how to take all of that hard work and now also train them on the registration of those documents so that they are accessible, again, when and where they're needed in the registry. Can you talk a little bit about some of the requirements that you need to meet surrounding advanced care planning?
Well, our Mercy Care is contracted with the Access. So we are the Medicaid with the All-Tex program, and it is a requirement by Access that we provide services to the members in regards to policies, procedures, making sure we maintain those policy and procedures and keep updated, like I said before, training with the case managers. Also, within our contract, we have to also ensure that the providers that we are contracted with also keep up with all federal, state laws as it comes in with advanced directives and continuing monitoring those.
Great. And as we've worked together, what I've noted is that around advanced care planning, there's a commitment to ensuring that these conversations are not just taking place to kind of qualify a checkbox, which often is happening. Someone comes into the hospital, we ask if they have an advance directive document, we check yes or no, but depending on, there's nothing else after that yes or no. If you have one, can we have a copy of it? Do we have the most recent copy? Let's look up in the registry if it's registered. If you check no, is this something you understand about? Would you like more information? So that is not the approach that I've heard from Mercy Care. So can you talk a little bit more about that?
Well, you mentioned it, Carla. We train with and educate the case managers on the directory, and working with PCPs and all the other providers that we do work with to ensure that we're able to get those documents in there. Our long-term care department, our goal is that 80% of our members will have an advance directive. And so we are continually working with as I mentioned before, new case managers, and then those case managers that have been around, continuing education with those changes. Last month we were at 79%. So we're almost there. And once you hit an 80% goal, then you have to increase the goal, right? Because you can always improve on what you're doing. The other thing that all of our members that come into the program, and this is with all Mercy Care, receive a member handbook. And in that member handbook, there is information in regards to ACP and the EOL. So when a case manager is meeting for the first time with a member, they review that handbook, they review all the ACP and EOL life and begin those discussions. But prior to them meeting, they also go to the registry and they utilize that information to see if there's already something in there. And if there is that information there, then they also ensure that we have the updated information. And if there's any changes, because of course a member can change their mind anytime that they want. So it's a team effort, and part of our process is to ensure, like I said, that the PCP and the providers, other providers that may be taking care of our members, are also included with all the information, and then we make sure that we have that.
And I want to applaud that number of 79%. If I'm not good at math, so I'm going to say that if there's 10 chairs at any of your tables here, I know there's 8, so I don't know the math on that, but I do know that if there were 10 chairs, that would mean that only 2 of the individuals at each table had not completed their document, and that is an amazing number. We're not going to raise hands, because I'm not going to do that, because unfortunately healthcare providers and those in the healthcare field do not have any higher of a completion rate on advanced directives, but I am hoping that we are going to see a huge influx over the next 2 weeks of directives coming in, and I'm going to associate that with this particular talk and summit. So thank you so much for that. So I want to talk now with Jennifer and Spectrum and share a little bit about working with your organization for the AzHDR. We did something a little unique, but something that we are able to do, and we ran a report of all the patients in a certain age range that your team identified to see who had directives in the AzHDR. And I understand that you're now using that information as part of the annual wellness visit. Can you share some more with all of us?
Yeah, so at Spectrum, being a whole health provider, so we do primary care and behavioral health. We are statewide and we're open to all ages, all insurances. So for us, we're in a unique position to talk to our members about advanced directives. The conversation for us started years ago because we have an internal medicine practice that sees mostly 65 and older and in the Medicare population. So that conversation wasn't new, but like was mentioned before, the access to that information is important, being able to have it for yourselves or your family members, because information is only as good as it is available. So if you can't have it available, then that can change the picture quite a bit when it gets to end of life. For us, what we've done is we've actually extended our wellness visit times in order to allow the providers to have that conversation, and it's all wellness. So it's not just, that targeted population or insurance, but really all of our patients that come to us, because really what we found with advanced directives is has to start with a conversation. So if you're not having those conversations with your provider or with your bank and your financial planning, it's really hard to, it happens in stages. It's not just we have this conversation once and I walk away. It needs to be a continual conversation. And especially as someone gets in the advanced stages of an illness, it's important to continue to have those conversations, because like was said, your preferences and your wishes can change. And so for us, it's all about making sure that patient choice is at the forefront. And this is one way of honoring patient choice. And in those moments, you can have family members that have different beliefs or have different wishes because it's their loved one. And it makes that conversation and those decisions a lot easier because you're honoring the patient's choice. And that's what's at the forefront of all the decisions that we make. By making those changes, there, for the providers, it is reimbursable activity in order to have those conversations, in their wellness visits, so it's not lost opportunity, and it's best care for your patients to have those conversations with them about their advanced planning. So for us, it's changing that narrative to being, yes, check, you have one, to this is something that as we see you for your annual exams that we're always going over, because you want it to always be current. You don't want to have an advanced directive, that you did 20 years ago and then it's never looked at again. It has to be something that's always part of the conversation as you move throughout your life.
That's great. And as you shared again, and many people don't always realize that there is a coding for these conversations that are reimbursable, and there's not a copay for patients at certain times, on the annual wellness visit and the first Medicare visit. So there's definitely opportunities in terms of integrating that, and if that's the first starting point, that's a great place to start. And with that, one of the things we often see when organizations are bringing in new programs is that they can feel overwhelmed by having to do it all at once. So can you share a little bit about how Spectrum is approaching the integration of the AzHDR with their other care planning initiatives?
So for us, we're taking a staged approach. So for us, the beginning piece of it was actually talking to our providers and then making sure that they have additional, time in those wellness visits to have the conversation. And then in the background, after you start having those, you have to put in a different workflow for your practice to make sure that you're uploading those documents as needed. And then on, the flip side, making sure that you have the most current one in order to have those conversations. So there is work that you have to do in the background, but really it has to start with your providers and educating, giving training and having those conversations, and then allowing time for them to have those conversations with your patients. So we're in the beginning stages of doing the background work as far as the uploading and downloading the information to the registry. We've already initiated the training and having the conversations and then changing our times on our annual visits in order to allow for that. And we've built in those reimbursement codes into our templates. And so it's just something that they check if they cover that in that visit. Making it as seamless as possible for the providers is, as you all know, if you work with providers, that's your best bet, is making it as easy for them to use and account for that additional activity that they're doing. But also on the back end, it gives you an easy way to be able to pull that reporting and know, okay, they had this advanced directive conversation with this patient, and you can go in and pull that information and upload it.
That's great. I want to follow up on that idea and share that other organizations are starting the utilization of the AzHDR with certain teams, for example. One is working first within their case management department, their emergency department, and one is focused on their chaplaincy program that has always been the team in the hospital that does these conversations. One of the hospice organizations began with only 2 team members using the system so that they could then give feedback on how best to train other staff members and integrate it into the process that they only could understand for themselves. So thank you so much. So after hearing how these 4 different organizations are using the AzHDR, I want to share some of the technical aspects and the registry itself. So providers, again, do not need to be participating with the Contexture HIE in that participation agreement. To access the registry, though, providers do need to complete sign-up and onboarding paperwork and then schedule training. The registry does allow for both submitting documents and viewing documents, and user access is determined by type. So healthcare providers and organizations, including first responders and EMS that are licensed in Arizona, are able to become participating providers and view all directives that are in the registry for the provision of care. Legal and financial organizations are able to submit documents on behalf of their clients and then view only those documents they themselves have submitted. Individual consumers are able to share their documents in a varied ways and then have access to see those documents as well as share those documents with others if they give them access through their wallet card. Social services and faith-based organizations are being trained on how best to work with the registry and share that information out as they're doing other advanced care planning. There is, I want to share a few of the other pieces. There is a review and approval process to validate all documents coming into the registry. So we manually review all advanced directive documents that are coming in, no matter where they're coming from, to maintain an integrity of the registry and to give assurance for healthcare providers that when they are looking at documents in the registry, they're documents that can be utilized in the provision of care. So we are rejecting and sending back to consumers or providers documents that are missing a physician's signature, for instance, on a DNR document. Dates don't match for witnesses or notaries. And then educating, again, organizations that may be having documents that we're seeing a lot of rejected reasons for on how to best put their template together to really minimize the issues of rejecting documents due to, again, people not realizing what is required. There is, as you'll see, a mechanism now for distinguishing documents that have been revoked or replaced. And so only the most current document will show upon any search. We do support the full range of forms under the Arizona State Statute for Advanced Directives and support all form types. So it is not that individuals need to send in their living will that is only from the Attorney General form. It can be any form as long as it meets the guidelines for what a living will is in the state. We do offer both ongoing support and training of organizations, both on the technical aspects, but as importantly, on the aspects of advanced care planning, continuum, and conversations in general. And we do have a functionality now for documents to be sorted by type. So when an account is brought up, it is not simply going to be all the documents in a folder, but you will see specifically if that patient does have a living will, if they have a mental health care power of attorney, and very important for our first responders, if there is a DNR, so they can go directly to that document and don't have to search through other documents. So it's exciting to see that where we were last year when we were standing here, everything we talked about was this is what is going to be coming, and this is what we think it is going to be looking like. And now where we're at, and it's going to be, we'll be celebrating our year. Letters went out to consumers with their final login the weekend of last Thanksgiving. That was a fun weekend. We got a lot of calls and questions. But we're really excited to be able to show that even in this year, we've made so many adjustments to what the registry functionality is because of the work of early adopters and champions in the state. So as a participating organization, your team will have, so now it's working really fast, will have a login. So they would go into their login page, and again, based on their login credentials, you will have different user functionality. If you only want certain members of the team to be able to submit documents and other members only to view documents, that is set up based on the type of login that they have. All names that you're going to see up here are, of course, from a test individual. Healthcare providers then search by name, date of birth, and if there are multiple listings, then there will be additional search criteria you can use to isolate your patient. This is how it looks on the screen. Your search will bring up documents that are active in the registry. If an organization or the patient adds a duplicate document, such as another living will, the system, through our manual review, determines which date is the most current, and that will be the only document that shows as active. The patient would have a history of what documents they had in their account that they can see in their own portal, but no one else would be able to see those archived documents. If a person has had documents transferred from the original Secretary of State, the search results will show as Secretary of State, and you would view those documents to see what is in that account. What we're looking at is being able to begin to kind of separate those documents out as kind of one of the next phases. Individuals can then upload documents and submit them on behalf of their patient or client. They can put them all in as one scanned document. They don't have to be separated out. We do that work on the back end. You'll just provide some information. And we have now, because the statutes do require a registry agreement, but we have simplified that for participating providers where that client does not have to have that registry agreement notarized. You as a participating provider simply signs that you were there and have identified who this patient or client is, and then that client just signs that registry agreement. So simplifying the process for participating providers. Because this is designed for consumers, it is known then that any documents that we receive, the patient is communicated with. Whether they have submitted the documents themselves or it is submitted on behalf of a participating provider, they will receive a letter or an email stating that we received your documents, we have reviewed your documents, and if they were sent in by a provider, who that provider is, so they are not confused as to why they are receiving this notification. It gives them then access to be able to set up their own account if they choose. They do not need to do those steps if that is something that they don't want to do or don't really have the technical skill to do. They are still active unless they reach out and want to inactivate their account with another registry agreement. One of the things we're really excited about is our new view-only access card. So if anybody wants to and can, they can take their phone, put it up to that QR reader, and they would then be able to view the directives in this format, open those directives, and be able to see what that patient has. So this is a voluntary card to carry. I have it in my wallet, for example. If I am found and am not able to communicate my own wishes, if I maybe end up in a space where a healthcare provider or first responder doesn't have yet participating access and so can't go in directly to the account, they can use this card and see my directives. They can't change anything in my account other than being able to see the directives themselves. Again, this is voluntary. My husband, for example, when he recently had surgery, they always ask that, great question, do you have advanced directive documents? Although oftentimes they don't ask anything after they just check the box. But he was able to proactively pull out his wallet card and give it to them to make a copy and keep it in his account. Which again got them very excited about this, and they then reached out and to learn more about the registry and how they could participate. But we're very excited about this new card and have made changes to it based on feedback from both consumers as well as providers, particularly our EMS and first responders who asked that if a DNR document does exist in an account, that when they do the QR code, it comes up first in the list. So they immediately know that that individual does have a DNR, and they can open it up and then view and act accordingly. Want to share a little bit about participation, because now I know that you are all eager to now sign your participation agreements after this. You can do that first, or you can do your own advance directive first. It's your choice, but sign something after our time together today. We do need you. As we shared earlier, these directives are really key, and a lot of work and time and money of organizations goes into completing these directives. But it's really important to be able to then access them and to have a registry that is valuable for other providers, particularly first responders, to then be able to go to and be able to access documents in there. So there's a couple of steps, and this is going to be first, I'm going to talk about the DAP program, but first just in general for any provider in the state. You would either just reach out to our team through email. You can fill out an interest form on our website, and we'll be reaching back to have conversations about how your organization operates around advanced care planning, and then how we can incorporate the registry with you. There is an organization registration form that just shares information about who's going to be kind of leading the charge in your organization, who will be the administrator on the account, and all that means is that that person can help with user setup, view some of the analytics, do some reporting back. Teams can be an administrator. It doesn't have to be one single person. Sometimes we have organizations who want their medical records team to be the one who is listed as the administrator. And then we do provide training and onboarding. You can see by the very few slides I had on the steps of the registry itself, it is a very simple and intuitive kind of program to use and operate. But we do have training on that, and not simply around the technical aspects as I shared before, but also thinking about, are there questions around advanced directives, the continuum? Are there questions on how you can enhance the work you're doing around those wellness visits and bring in more clients to have those conversations and be able to bill more for those visits? So there's a lot of different ways that we can be working with your organization. This year, DAP has the program, the Differential Adjusted Payment Program, has some specific requirements for the following provider groups that are up on this list, including hospitals, critical access hospitals, psychiatric hospitals, residential treatment, subacute facilities, and specialty per diem hospitals. But again, don't let that small provider kind of group requirement limit you going and participating with the AzHDR's. We continue to build out. We continue to see that the DAP requirements and provider types will also be increasing. There are certain milestones that then need to be met for those particular providers. First, just by November 1st, so if you are on this list, that there's an SOW to initiate, and then no later than March 1st, signed healthcare registry agreement, and then begin to use the platform by September 30th. What we're seeing is that organizations who are signing that SOW and getting it back are kind of way going faster than the rest of the timeline, because again, there's really no reason to wait. Let's just get going and putting it in place. So while those are kind of end dates, it doesn't mean that we have to wait once we get the participation agreement in place. It is my hope that with the work that all of these panelists are doing and the conversations they've had for their programs and the sharing of the information with all of you, that you have already begun to understand and know what your why is, both personally and as an organization, and that you are making a plan to document and register your wishes, not only for yourself and family members, but thinking about how your organization can build to be able to do the same for all of their patients. Questions, feedback, here are some different ways to reach us. There is a specific email for DAP questions. You can always reach out to myself. The manager of the program, Valerie Reese, is here and also at our booth. So please feel free to reach out to either of us or in general, and we would love to have further conversations. And so with that, I would like to be able to open it to any questions for myself or for any of our panelists.
I'm interested in the billable code that you're billing during the annual well visit.
What the actual code is? You asked me the one question I don't know off the top of my head. If you want to write down your information, I can email it to you.
Okay, perfect.
So the question was the actual code for the annual visit. And while Jennifer was going to share that, I can also put that in with the slide and add a slide when we're sending these out. And we'll share some more information with those visit codes as well.
And I was just going to say, Banner, we've been using the codes. I don't know the code offhand either. But usually your coding department or coders would easily be able to find that. Just another thought. But my question is, this is great, love it, and I recently got my trust, so they didn't really explain this. They just said, do you want this part of the registry? So I thought that was great, and now I fully understand it. But how are other states, like, do you know how the other states are? Because, for example, I'm with Banner, and we're in many states, and so just kind of wondering how we're trying to get this more nationwide as well.
It's a great question. So the question really was, how are other states doing registries and working with advanced care planning, knowing that a lot of the organizations here do have other state involvement. There are very few registries across the country, and even fewer. We are the only one that is through a HIE. And even those that have been regulated through statute are not doing it through the HIE. There's some private kind of sectors. I do see some of that changing, particularly for the POST documents. We kind of saw more of a national approach to POST documents. And so I think that that may be a good kind of lead in looking at this. While only healthcare providers who are licensed in Arizona can access the registry through a participation agreement, if a client does go, let's say, I know there's a lot of Minnesotans who are in Arizona, if they go back to Minnesota, they could give them their wallet card, and as long as the client has given that permission through that wallet card, they could then look it up, but they can't go into the registry on their own. We do accept documents from other states, and documents across the country are typically accepted wherever you are, as long as you are not asking for something that is illegal in that state. It doesn't invalidate the entire document, but it would invalidate that section. So for instance, in Oregon with the death with dignity, they can't bring that document here and anticipate or expect that any health system would honor that, but the rest of the document, as long as it is completed correctly from that state, the rest would be honored. So we see some changes and growing, but because there is not, unlike Pulse, there is not a single document that really works across states. There's not a single way that these documents are to be legally completed. And in many states, they're not even regulated, unlike Arizona, that is very specific statutes. Some states don't do them by statute. It's really done by kind of just an agreement within the medical community. So hopefully that helps.
Yeah, thank you.
Carla, this was great, and I do have my directive done. But I didn't know about the registry, so I have no idea. I'll have to explore that. My question for you is, when you are working with an employer, is this usually through the HR department? Is that how it gets started, or is it through, where does it usually start with in an organization in terms of getting them to use the registry?
Okay, great. So the question was, one, we want to say great that you have your document. I do have a registration agreement at my at the booth, so you can come and pick that up and have that notarized over the next few days and send that in, and then you'll be really in good shape. And the next question was kind of where does this often start within organizations? And so it really depends in what aspect we're talking. So for instance, for the participation with the AzHDR as an organization, it's typically starting with the kind of the C-suite group in terms of getting the information, or in their IT who's handling other DAP-related or technical kind of HIE-related arenas. And so it's starting there. They're often then kind of signing it, but then moving it away into other locations because that's not what they're focused on. So oftentimes then, again, it could be an organization that their chaplaincy program is now taking it over. But the participation aspect is completed, and then they just move it to other departments. In terms of where for organizations for their own employees, I think it is a great way to start within the HR. Contexture, for example, incorporated, because again, we're going to walk the walk. So we now, in our benefit handbook, there's a section on advanced care planning. Conversations can happen, questions can be brought to the AzHDR team from any employee during on April 16th, which is National Healthcare Decisions Day. And two things you can rely on, taxes and death. And so April 15th being tax day, of course, April 16th is National Healthcare Decisions Day. But we do a week-long group of videos and training, lunch and learns. So we also do have ways for any organization to incorporate any kind of wellness program around healthcare directives. So you can download any of our National Healthcare Decisions Day materials. You can access the videos. You can access our quiz and trivia games, and it gives some information about how to set up kind of information from an HR perspective. So it's great to have both because, again, there's no higher utilization of these documents by healthcare providers, but I am a big believer, and we have a flyer at our booth. We should not be having advanced care planning conversations with our patients or clients if we ourselves do not value the documents enough to have done the work. We don't know the kind of questions these discussions bring up if we haven't had to think about them truly for ourselves and our families. So it's a great way to do them at the same time. It's one of the reasons lacrosse was so successful, because you could not have all of the staff was certified to be having these conversations, and to receive certification, you needed to complete an advanced directive document. So hopefully that answers.
Thank you.
We just have a few more minutes for any other questions. Again, we do have a booth, so please feel free to come and talk with myself or Valerie or Gina, who are at the booth today. If you have any questions for our panelists as well.
If somebody did want to prepare documents through Desert Financial, do you have to be a member, or can you help anybody?
No, we help members and non-members alike because it's legal access to the public through the Certified Legal Document Preparation Program that the Supreme Court sponsors. So, and I think I'd just like to add the conversation across the board here is that the directives are not one and done, right? I think that if you prepare your directives in your 20s or 30s, that you're likely going to be naming your parents or your siblings to be your agents and responsible people to speak for you in your incapacity. And then maybe when you get older and your kids grow up, maybe you appoint your kids to take those roles. And then when you're in long-term care or you're thinking about closer to end of life, those decisions can change again. So it's an evolving event.
That's great. That reminds me that, again, there's they talk about the Ds for when you should redo your documents. Every decade, Upon death, and that means any death within your family or friends, often brings up for yourself things that you would like or not want for your own situation. Disease or change in diagnosis. So either a new diagnosis or change in your disease are often times that you should really look at, or divorce. And again, that doesn't mean maybe it is a divorce in your home or a change in a family structure, to go back and look at your documents. If your ex-spouse is still on your healthcare power of attorney, it will be your ex-spouse who's making those healthcare choices for you, which may not be who you would want. So if there is a change in family structure, you definitely want to make sure that you're looking at who to do that with. I suggest when you do complete your document, put on the back of your original copy, which you do not want to send to us, put on the back of it where you have put your documents, so you know exactly where to go back to change when you change them, and who to pick them up from and give them new copies. Melissa.
So I've got two questions. I was really intrigued by the concept for the certified legal document preparers. Do you know by chance like how many organizations in Arizona have that designation?
That's a good question. I know from a financial services standpoint that Desert Financial is the only organization that I know of that actually has that as a designation for the legal entity of the credit union, but I think there's a court person in the room, or a former court person in the room, that might know that answer to that question.
Thanks, Matt. That's a great question. There are about 675 certified legal document preparers in Arizona. That includes about 500 that are individuals who either work for or on behalf of the close to 200 certified business entities.
Oh, great. And then the other question, I was definitely intrigued by the question about, as an organization, how can we encourage our employees to get their documents completed? For any of the panelists, do you all have experiences or examples of things that you've done within your own organization?
I don't.
Just added it to the to-do list.
Okay.
Yes.
So everyone should add
We
it to
are
their
now.
to-do list when they go back to their organization.
I think that if you make the topic as part of your employee wellness program, that's probably a great start to bring awareness of the importance of that. A lot of our younger employees at Desert Financial are they're in that category in their 20s and they're invincible, right? And really we find that it could be a tragedy if there is an incapacity that's unforeseen, right? And so I think just bringing awareness in your employee wellness program is a good start.
Great. I'm always interested in all the different ways that different organizations can help advance this concept. So if there's any other great ideas in the audience, feel free to get up and share those.
And remember, whether you are participating at this time or not, the website at AzHDR does have materials to help you as an employer to set up programs. It gives ideas for, health fairs. It gives ideas for, again, trivia contests, things like that around a topic that, we don't really think about typically in that way. But definitely, there's a lot of resources and tools to use. And again, share, as Melissa said, share those ideas, because the way that we have been redesigning some of the materials and the programs and the forms is based on all of the champions out in the community, and what they have shared is working best within their own organizations. So with that, I would like to just thank you all for your time. I absolutely am excited and look forward to the work that we continue to do with the 4 panelists and their organizations here, but even more so, or as much with all of you as you continue to participate with the registry. So thank you.